The direct antiglobulin test, DAT. Another way of looking at this is the direct AHG test, as opposed to the indirect AHG test. So the DAT is used to detect in vivo sensitization of RBCs. So do we have antibody bound to RBCs in our body? It's also called the direct Coombs test. It's kind of an old school name for it. Normally RBCs are not coded with IgG or complement in vivo. The DAT detects IgG or complement antibodies that have bound to patient cells due to a clinical event, such as being given passive immunoglobulin therapy called IVIGG therapy, Winrow, which is a thing to help combat hemolytic disease of the fetus and newborn, or someone receiving ABO-incompatible plasma products. The direct antiglobulin test has no incubation phase, where the indirect antiglobulin phase does. So some applications of the DAT. Some clinical events affecting the DAT is hemolytic disease of the fetus and newborn, hemolytic transfusion reactions, autoimmune and drug-induced autoimmune hemolytic anemia, drug-related mechanisms, and passively acquired antibodies, such as the IVIG therapy. So how do we perform this DAT? It's a really simple procedure that a lot of times, especially in clinical situations, to go, hey, do a DAT on here. And because a lot of blood bank procedures are complicated or complex, this messes people up. It's a very straightforward procedure. We're taking the patient's red cells. We're going to wash them 3 to 4 times in normal saline. Doesn't need a whole lot of red cells, just a couple drops. Then we're going to decant the saline to a dry cell button after those 3 to 4 washes. We're going to immediately add our anti-IgG or the AHG after washing. We're going to centrifuge and read it. Then if it is negative, we're going to check all those with IgG sensitized red cells. They're called check cells. It's going to make sure that the AHG was not neutralized, and a positive reaction should be observed after check cells have been added and recentrifuged. So kind of going over this a little bit, we wash these red cells to begin with because we haven't technically added anything to it, it's just patient red cells. We want to remove any unbound proteins that may bind to the anti-IgG and neutralize it. We add that AHG after washing immediately to prevent globulins from disassociating. We don't need an incubation phase with this procedure because the antibody-antigen complexes are formed in the body. My DAT is positive. What do I do now? We want to look at patient history. Have the patient been recently transfused or pregnant? Have they received ABO-incompatible plasma-containing products? Have they received any medications? There is a list of medications that can cause positive DATs. Is the patient receiving that immunoglobulin therapy or Winrow, which is an anti-D therapy? Does the patient have unexpected alloantibodies? Further testing includes eluting the antibody from the sensitized red cells for identification. And we will talk about that. So for positive DAT, it's going to indicate a potential immune-mediated RBC destruction in the body, extravascular destruction. Transfusion reactions, if a donor RBCs have the recipient's antibody bound to them, we're going to be looking for a mixed field reactivity. So we have mixed field meaning that, normally we would see, like a 3+ with those big clumps in there with a clear background. You may see those big clumps with also like hazy, unagglutinated cells in there as well. So for hemolytic disease of the fetus and newborn, fetal RBCs have maternal antibody bound to them. For autoimmune hemolytic anemia, the patient autoantibody is bound to the red cells. And for drug-related, patient RBCs have an antibody to a drug complex bound to them. Some drugs some drugs give you a positive DAT in the presence of the drug. Some drug will cause positive DATs. So for warm autoimmune hemolytic anemia, sometimes written out as WAIHA, or sometimes say you have a warm auto. Positive antibody screening panel with all cells tested in AHG phase. That's one of the biggest keys. You'll have a positive DAT and or autocontrol. A lot of times the positive DAT and positive autocontrol kind of go together for IgG. Autoabsorptions may be attempted after chemical treatment of the cells to allow for detection of an underlying alloantibody. A little bit on this because we don't get a whole lot into this even in lab portions of it. So with an autoadsorption, that means that's the person's own red cells. We're going to try to attach things to the patient's red cells to remove the interference from that plasma. We can only do this if the patient has not been transfused recently, Why? Because we don't want to adsorb onto the donor RBCs, which may have those antigens on there. We could risk absorbing out clinically significant antibodies. The chemical treatment comes from the fact that if we do have a positive DAT, we do know that we have antibody attached to these red cells in vivo. We want to give them a chance with the chemical treatment to knock some of those antigen binding sites off so we can try to adsorb it back in our red cells in vitro or in our lab to see if they have any underlying alloantibodies. The cross-match is going to be incompatible, which I kind of talked about last lecture, the one before that one, and a physician must sign a deviation from a standard practice to issue these units. But very classic symptoms for someone who has a warm autoimmune hemolytic anemia or a warm auto. So with warm autos, about 67% of the time, we're going to have anti-IgG and anti-C3d attached to these red cells. About 20% of the time, we're going to have just IgG attached to the red cells with no detectable complement code to the red cells. And then in about 13% of cases of warm autos with cold hemolytic disease and paroxysmal cold hemoglobinuria, we'll have no positive IgG on there, but a positive complement. But with warm autos specifically, we see obviously that 87% of the time at least have some sort of IgG attachment. Cold autoantibodies, sometimes the bane of my existence. These are normally detected with ABO discrepancies or incompatible immediate spin cross-matches. We can also detect these because the cold autoantibodies like to show up in more sensitive testing methodologies such as, gel technique or solid phase technique. They may look like they're clinically significant antibodies, but with the proper resolutions, we can see there's nothing actually there. They are usually clinically insignificant. They usually either have an anti-I or anti-IH specificity. The most common cold autoantibodies are auto anti-Is, and a ton of people have them, and you'll never know because you don't normally are tested for it, and they're not clinically significant. The DAT is usually only positive with complement only. That's the C3. Pre-warming may be used for cross-match and antibody resolutions if the patient has not been recently transfused. In my facility, and depending on the facility where you're going, will determine how they do pre-warming. We don't do pre-warming at all. What we will do is for our cold auto adsorptions, especially if the patient has not been recently transfused, just to try to pull out those cold autoantibodies. And so just kind of like we did with the warm autoantibodies, you think about where that antibody is reacting. If we're talking about a warm autoantibody, we're going to try to incubate those red cells in 37 degrees to pull out the warm. And then in cold autoantibodies, we're going to try to incubate those cells at 4 degrees to pull out these cold autos. So an elution. An elution is the removal of the antibody bound to the RBCs for the purpose of the identification. With elutions, I'm not really concerned with my red cells after I chemically treat them. I'm concerned with what was bound to my red cells. Elutions are performed on a patient with a positive DAT that has been transfused in the past 90 days or 3 months. The eluate is the solution that contains the removed antibodies. And this is tested the same as a patient plasma for antibody ID. So all we're doing with this is taking a bound red cell, we're chemically treating it to remove those antibodies and to keep them in a suspension that's going to be good for testing, but I'm not concerned with my red cells at that point. So we have a couple different methods for elutions. We have an acid elution, which is one of the most common types of elutions performed. This reduces the pH of the sample, which causes disassociation of the antibody from the RBC membrane. Acid elutions, again, we're not leaving you a whole lot of good red cells to deal with because we're really only concerned with what antibody is in the eluate, which was attached to our red cell. Organic solvent elutions denatures the antigens, causes the antibodies to be released. A lot of times these aren't used very widely because they're cancer-causing solvents. You can also do heat elutions. These produces changes in the conformation of the RBC, causing the antibody to be released. Best for IgM antibodies because they don't like to hang on to those sites when you heat them up a little bit. Also called like soft heat elutions because we're not heating them up enough to hemolyze the red cell, but just to kind of get those antibodies to lose their binding. Finally, an interesting one is a Louis freeze-thaw elution. This lyses the RBCs to release the bound antibody. We use this for the ID of antibodies for ABO, hemolytic disease of the fetus and newborn. This is a kind of a tough one to read because it's in the name. You take the RBCs, you're freezing them, and we know that's going to hemolyze the red cells when we thaw it. So we're essentially breaking the RBC up, for all we have really is like a hemoglobin mixture in there with potential antibodies. So kind of nasty to read, but really good for doing that, ABO-HDFN antibody identification. So the eluate, once we've disassociated those bound antibodies from a red cell, is tested against a panel of cells in order to identify the bound antibody. This is used in the same proportion as plasma, 2 drops to 1 drop of red cell. Enhancement medium may be used depending on the strength of the DAT. So if we don't think we're going to see it without, bumping up with that enhancement medium, a lot of times people will test these the exact same way they did the panel. Elutions may be performed in any case where the DAT is positive. So it doesn't necessarily have to be not transfused in 90 days, because we may truly not know. Some people, if they have a positive DAT and don't have a history of it, we're going to do an elution. Usually performed with the goal of detecting newly forming antibodies. Eluates may be negative in some cases with autoantibodies or in some drug-related mechanisms. In the case of autoantibodies, usually all the panel cells react. It's one way that we try to kind of hone into, are they on some sort of drug causing a positive DAT, because we may be given a drug list that's incomplete, or they may have been from one facility to another, and the new facility is not aware they're on what medications they're on. So a lot of times if we're seeing a positive DAT and we go to do an eluate and the eluate's negative, a lot of times that's directed against a drug. So an antibody identification is performed the exact same way as plasma. Rule-outs are performed. Rules of 3 apply. The antigen typing must be performed if an antibody specificity is identified. So we're going to do kind of this procedure just like we would with plasma, because we're really talking about what antibodies are we identifying. For transfusion reactions, these can occur in cases where the patient has previously undetected antibody that coats the donor RBCs. The patient can be recently transfused, and a positive DAT is the first indication of a newly forming antibody. We're looking at here for mixed field reactions. An elution study would be indicated there. Sometimes we can see these in the eluate before we see them in the plasma for newly formed antibodies. Touching a little bit on the hemolytic disease of the fetus and newborn, a DAT is performed on the cord blood sample. Cord blood studies are routinely performed on Rh negative and type O mothers. These may be performed on any sample if there's an evidence that the mother has an unexpected alloantibodies. One of the most common hemolytic disease of the fetus and newborn is going to be with ABO incompatibility newborns. The elution would be indicated if the DAT is positive without a maternal fetal ABO incompatibility, again, which is the most likely reason. So lastly, we have drug-induced hemolytic anemias. These normally produce strongly positive DATs. The antibody eluted from these RBCs reacts only with the drug-treated RBCs. So kind of like I said before, when we have someone suspected of having drug-induced hemolytic anemias, I see that positive DAT, I'm going to perform like an acid elution. When I test my eluate, I get no reactivity. In order for us to see it, to confirm it, we need to know what drug they're on, and then we will treat the panel RBCs with that drug and then retest it, see if we have reactions. Hemolysis is going to develop gradually but may become life-threatening if the etiology is unrecognized and drug treatment continues. Some of the associated drugs with drug-induced hemolytic anemia are methyl dopa drugs. These are notorious for causing positive DATs, probably the most likely candidate. Larger doses of penicillin, cephalosporins, that was the last one I dealt with that we had drug-induced hemolytic anemia, fludarabine, and procainamide. So again, with this one, not a whole lot of slides, but a lot of information going on with it. So take it over, chew it up, digest it, and we'll go from there. See you next time.